All right, so chapter 6, lifting and moving patients. So this really should be a review for all of you, right? All of you are, I believe, are currently working on an ambulance somewhere, so you've had the opportunity to lift and move patients around, but it'll be a good review to kind of have an understanding of, how we move things around. With that being said, I don't test a lot on this stuff here, right? To me, this is important, but not as important as learning AMP and different assessment techniques and things like that. All right. So lifting and moving patients. Get my pen back on here and we'll get started. All right. So you will have to move patients several times. It will happen when assessing, treating, transporting the patient, whether it be getting them onto a longboard and then off a longboard onto a scoop, off a scoop, to assessing the spinal area, to assessing the buttocks, to the back, to the legs. The patients are going to move, right? Seated positions and laying down, or when you go to that nursing home for the respiratory distress and they're laying down flat and you're like, what are you guys doing? This is horrible. Sit them up and all magically they're better, right? So we're going to see that kind of stuff. We're going to be moving patients from supine to lateral to whatever it may be, right? But patients have to be moved into a different position or location, will likely involve the use of the backboard, the stretcher, or other kind of devices. So when lifting or carrying a patient, you will need to know how to perform the emergency body drags and lifts, rapidly move patients from a vehicle into the stretcher. So those would be more of your rapid extrication, like your cardiac arrests, to significant respiratory, to things like that. The patient has to get out of vehicles on fire. Might want to get them out there pretty quickly with their proper gear on. Lift a patient from the floor to the stretcher using proper techniques with that. Carrying a patient up or down stairs, utilizing stair chairs, and then placing a patient as well on spinal boards and whatnot also. I don't know what just happened here. There we go. That's better. All right, so we have different ways, different devices we can utilize. We have ambulance stretchers, backboard scoops, folding ambulance stretchers, stair chairs, basket stretchers, or the Stokes basket, flexible stretchers. There's all these different things when we're moving in patients around in different devices. All I can say is on this slide, know what your service utilizes. Whether you have a track stair chair from Stryker, if you have no track stair chair, most services have track now to go up and to go down the stairs to help relieve any kind of weight, which makes things so much easier. Understanding your stretchers. And as much as I want to say we've been spoiled, but most services have auto loads now, power load systems. So there's no lifting of a stretcher into the back of the ambulance, right? They've taken that ability away. Now, is that a good thing? Everybody should be going, yeah, this is great. I'm so glad that it's been taken away from us. Until the day that your battery dies on your stretcher and you have to do a manual lift. Okay. So don't lose that skill of how to use manual stretchers because it is a skill you need to know. And because of the fact that our power cots are powered now, they have a pretty significant hydraulic system that are on those and they are heavy. And picking up a rack on the bottom of for a stretcher on a normal stretcher without using power stuff is pretty easy, pretty lightweight. It takes a lot of power behind it to move those wheels up on a stretcher that is power load or power setup. Takes a little more power behind it. And understand how things work. Like, for example, strikers, anything that is red on a striker is a movable part. No matter what it is, stair chair or not, if it's red, it moves. Right? So that's something to keep in mind as well. Not a lot of people know that, which is interesting. All right. So body mechanics, a little bit of A&P review. And this is the basics of A&P review. We're going to go way more in depth. We start talking about bone structures because those normal bones you used to know as an EMT, I'm not saying you memorize all 207 bones in the body or 206 bones in the body or 207 if you have Wormian bones, but we'll discuss most of those bones you need to understand. But the basics right now, proper body mechanics should remain paramount. So when a person is standing upright, the weight of anything being lifted and carried, and the hands reflected to the shoulder girdle, rib cage, or spinal column inferior to it, the pelvis, and then the legs. Right. So weight is transferred. which is why we have to have proper body mechanics. So in lifting, the shoulder girdle is aligned over the pelvis, hands are close to the body. Never reach out. Don't reach out in front of you to lift something, right? I don't care how powerful you are. It's not fun. I'll tell you a quick story here in a second, but hands are held close to the body, and the force exerted against the spine occurs in an essentially straight line down the strong stacked vertebrae in the spinal column. I was out of work for 2 weeks. I'm going back years ago when I used to work for Northeast Ambulance, long time ago, probably in the early 2000s, right? And I went to reach over the stretcher to grab a cardiac monitor, which, by the way, they weigh about 10 pounds, the X series monitors, and I threw my back out. It popped. I went down on the stretcher. I had to get transported to the hospital for evaluation. I was out of work for 2 weeks doing rehab, and I finally got to come back. Thank God it was only 2 weeks, right? So something that simple as a 10-pound cardiac monitor put me out of work for 2 weeks, and it could have been longer. Thank God I was in really good shape back then, and I took care of myself. So with that being said, having the muscles in my back and everything else from going to the gym protected me. It helped me get back into service faster. I was also a lot younger than I am now, right? The older you get, the more it hurts. But my back still hurts from time to time, and it's probably from that back injury that I had. And I've managed 25 years in EMS so far, and I'm still going. So keep the back in a straight, upright, vertical position and lift without twisting or bending, as you can see here. Yes, these are the old Stryker stretchers, right? So very little strain occurs against the muscles and ligaments, keeping the spinal column in line, as you can see here. Proper lifting techniques. Always make sure that your hands are curled underward like this. If you hold them up like this and down, it has a potential where all the weight's on your fingers versus on your palms and your wrists lifting up this way. Right? This can hurt your back. Right? This hurts your back. Please do not lift like this. And I see people do this all the time. Yeah, it's going to suck getting down in a catcher stance and lifting. Right? And you'll think this is probably easier. And yeah, this will probably work for a while until that one day you have the wrong patient, you make the wrong twist, then pop. There goes your back. Then you're out of work. All right. So remember, you don't want to do it this way here. Okay. You're putting a lot of strain here, a lot of strain in here, and this is where you're going to feel that pop, the muscles, right in this area where I'm circling all red, right? And those are a pain in the butt to heal. It's rest. And how often do you want to lay in bed all day? Yeah, it's great. You say, I'm going to lay in bed one day. How about 2 weeks of resting? Taking medications like Flexeril where you can't drive anymore for muscle relaxants. And then just the pain and constant pain. Next thing you know, you're on different medications for pain as well to try to reduce it because you can't take it anymore with NSAIDs or Tylenol, right? This is a road you don't want to go down, right? Shoulder injuries are the same thing. Make sure you're lifting appropriately. Just because you can He-Man something or doesn't mean you should be doing that, right? Take care of yourself, please, please, right? I don't know if any of you ever had a back injury before or pulled a muscle, right, and been out of work. It's not something you ever want to do if you haven't, so take care of yourself, right? So proper lifting techniques. Legs should be spread about 15 inches apart. These might be some test questions here, right? I do have to quiz you a little bit, but I don't hit, like I said, I don't hit heavily on this stuff here. Place your feet so that your center of gravity is properly displaced between them, right? With your back held upright, bring your body down by bending at the legs. If you don't have strong quads, then you need to start working out more and make them stronger because you're doing a lot of lifting with your legs, right? You should be able to lift 125 pounds off the ground. That's a normal lift test you would get for any kind of private ambulance service is about 125. Remember, because you're splitting it between your partner. All right, properly grasp the patient or the stretcher and lift the patient by straightening your legs and raising your upper body and arms until you are again standing. All right. So Laurel can go over different lift techniques if you ask her to on your practical day. All right. Do not lift the patient or a heavy object with your arms outstretched. Okay. That causes your body to go forward, causing strain on your back and also on your shoulders. Right. Last thing you want is to tear your shoulder. Right. Hold your arms up. Hold your arms so that your elbows, are aligned with the sides of your body. Keep the weight you are lifting as close to your body as possible. It helps distribute the weight better throughout your spinal cord. All right. Avoid placing lateral force across the spine, sideways leverage against lower back. Now, how often do we go to a cardiac arrest? I'm going to call it the commode code, right? Where they code in the toilet and they fall between the toilet and the wall. Are we going to be able to lift normally? Probably not, right? We're dragging stuff and things like that. I get it. But a simple little twist and lift could put you out of commission for a long time. So be very careful. All right, I understand the practicality. I'm not just a desk medic. I am right now, but I'm not just a desk medic normally. All right. And I understand I've been in the field and I've seen some weird lifting techniques. I've done some myself. I'll be completely honest with you. And you got to protect yourself the best you can. You're going to come into situations where you're going to be doing some weird twists. Just make sure you're doing it right. When you're lowering your stretcher, reverse it, what you just currently did, and avoid bending at the waist. This right here is what is going to hurt you, is that initial bending at the waist, because you're putting all that strain on your lower spine and your muscles, and that's where you start getting those back injuries. So the proper hold are your palms face up. You want to keep your hands at least 10 inches apart. Insert each hand under the handle, like I mentioned before. So this, my pencil here is the handle. It comes up underneath like this. All right, that way we can hold it that way. We're going to curl our fingers and thumb tightly over the top of the handle, and then we're going to make our lift in that direction. As you can see here, the hands are, I lost connection again. That's nice. And we're back. All right, so the hands here, as you can see, the fingers are curled in that direction. All right, making our lift. All right, never come up and down this way, over the top. Some team actions must also be coordinated as well. Remember, only one person counts, because the last thing you want to do is have yourself lifting and the other person not lifting, and that throws things off. I've seen patients get dropped before on stretchers. I've seen patients get dropped on backboards as well. All right, you guys just lose connection?
Yep.
Yep, I completely lost. I'm still on with you guys.
I can hear you, I just can't see anything.
Yeah, my separate screen just literally just shut off. I can't wait to get into my house this week that I'm buying, and I'll have faster internet here. Things will actually connect better. All right. I'll come right back in a second here. Stand by. All right, you should be able to see the screen again. Yep, okay, we're back up. Perfect. And switching to USB, and we're here now. All right, remember that preparatory commands. So ready to lift, lifting on 3, 1, 2, 3, lift. Please don't be the guy that lifts on 2. All right, so make sure you're lifting on 3 and lift up. All right, one person's in charge as well, as we just mentioned here. And 1, 2, 3, lift on 3, 1, 2, 3. Remember the word stop means stop as well. All right, so the body drag. So use the same body techniques or mechanisms and principles as moving, lifting, and carrying. Keep the back locked in an upright position. Avoid hyperextending your back. Keep your reach within the recommended distance. And during pulling, extend your arms no more than about 15 to 20 inches in front of your torso. All right, as you can see here, this is more of a blanket drag, which makes life a little bit easier. All right. All right. So pull the patient by slowly flexing your arms. So if you have the patient here, you're going to slowly pull them towards you. And avoid situations that involve strenuous effort lasting more than 1 minute. So you want to kind of hold yourself there for long periods of time. Right, that'll cause more damage to the muscles itself and start tearing and pulling. Moving across the bed, kneel on the bed to avoid reaching beyond the recommended distance. All right. So yeah, sometimes you have to get in bed with your patient to slide them or slide them into you. Just be careful. And a lot of things can be done in multiple moves. Okay. As you're moving a patient off a stretcher to the bed, you get them onto the edge of the bed as you're still holding and then slide a second time. Or you could slide them to the edge of the bed, then do your lift onto your stretcher. Remember to use gravity as your friend. So I always use, if I'm taking a patient off a stretcher going onto a bed for a transfer coming out, I'll make sure the stretcher is higher than the bed so that the gravity helps getting the patient down. Okay. Don't make it like a 6-inch drop or anything, but just enough to be able to help with gravity. Same thing, putting a patient in from a bed to a stretcher, bring the stretcher a little bit lower. Or they slide nice and easy onto it. Remember, their backside is sitting down in their bed. So bringing that down helps them slide over, and you can slide them up and get them into a position of comfort. Right? If they're on a backboard, then transfer the patient from the stretcher to the ED in the hospital room with a body drag. Right? I'm not a huge fan of backboards. I was back in the early 2000s when they were really popular and big. I'm starting to realize now more and more that it's a lot better with them out being on it. And scoop stretchers have definitely made a comeback. I love the scoop. I think it's a phenomenal deal. And for those of you that have Lucas devices, the scoop and the Lucas device board in the bottom are the same curve. So it definitely fits better when you're working a cardiac arrest. Use a scoop over a backboard. Just kind of a hint if you guys have Lucas devices, haven't trained much with them. All right. Other things to watch out for are soiled sheets. Okay. Last thing you want is to get the icky, gooey, sticky stuff that's not yours on you. All right. So protect yourselves. Let's see what else. Other things to prevent when moving a patient across the bed is the Foley catheter. If they have a Foley in place, if you go to a nursing home to transport a patient out, please, please, please make sure that the Foley bag is on top of the bed with them as you transfer them over. Because if you pull that out, it's going to cause a lot of urethral damage. Because remember, there is a balloon with 10 cc's of air in it that pulls through a very tiny urethra and can cause significant bleeding and damage if it pulls out. All right. So again, make sure that the Foley comes with you. And if it's full, a little helpful hint, have staff at a nursing home drain it before you go. Because the last thing you want to do is puncture that. That's a lot of pee. You don't want that all over you or your stretcher or the back of the ambulance. And take note how much came out. Sometimes the nursing staff likes to know ins and outs are a great thing. All right. So 2-person body drag. So another person or you and another provider may also have the ability to pull the patient with one on each side of the patient pulling. It definitely makes life a little bit easier. Alter the usual pulling technique to prevent pulling sideways. The one thing that, for me, I'm 6'4", so if I'm with someone who's like 5'10", as a provider, it makes it difficult to lift as well because I'm so much taller than they are. So it's easy if you have people the same height as well when you're doing stuff like that. As far as log rolling a patient goes, kneel as close as you can to the patient's side, as you can see here. Make sure someone's holding C-spine. If there's only 2 people, where that female is right here. Oh boy, let me go back. I'm gonna put my pen back on. All right, so where the female is positioned here, my hand would be there, and this hand here would be more down towards the hip. All right, if I didn't have 4 people. And how often do you respond with 4 people to a call, right, on an ambulance? Because you got an engine company coming behind you, you don't get 4 people. So one at the head, female here, hand over here, and then you do your log roll. And then you can palpate the back, then roll them back down on to the board. Very simple BLS review. I don't know why they show 4 people. That never happens. We don't get 4 people on a call. All right, so rolling a wheeled ambulance stretcher. Very important that you always go feet first. The only time you'll ever see me go head first if I have a psych patient on the stretcher so they can't plan the route of attack or a route of escape. If they can't see it, they don't know where they're going to go. With dementia patients, I always turn the buckles over because they like to push buttons a lot. So I always flip the buckles over and then click them in that way. So that way they're trying to feel things, they can't unbuckle their straps. Little things you pick up on in the facility transport world at their time. But as you're walking, though, you have to have hands on the stretcher. Either up here or down here is fine. And then you have to have a hand on the front pulling. right? If your partner has to step away and they walk away from the stretcher, you should never take your hands off that cot, ever, 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 right? What's going to happen is you're going to be on that slight decline, and you're going to step away for a second. The patient's going to be down the road somewhere, and you're chasing them down, right? Or you're on that decline of a hill somewhere, and it tips over because your stretcher is in the all the way up position like this, right? So once the patient's loaded, make sure you bring it down about halfway. That way there, it lowers the center of gravity, so less chance of it tipping over. Use a device that can be rolled to move a patient. So use 4 providers to carry a stretcher. One advanced EMT in each corner. I love how they changed that to advanced EMT. You can't have EMTs holding it anymore. But lifting and carrying a patient on the backboard or stretcher itself. It's great to have 4-point, but we live in New England, right? Small farmhouses, small door entries. Good luck getting 4 people through. Right. So again, you keep things close to your body and lift. If you have to put it down, then you say, we need to stop. On 3, we're going to lower the patient back down to the ground. 1, 2, 3, lower, then transfer people out if you're too tired to carry. So weight and distribution. So estimate the patient's weight before attempting to lift the patient. At this point in time, I do not care about kilograms. Right. Patient weighs roughly 250 pounds. We'll convert it later in the ambulance for medication administration, right? Patient weighs about 250. So know how much you can comfortably and safely lift, right? If you don't think you can lift it, don't be afraid to call for manpower, right? Please do not try to, like I said, the He-Man through it, because if you do that, someone's going to get hurt, whether it be you or the patient. Know the weight limitations of your equipment that you are using and place the strongest advanced EMT at the head of the head, at the head end. That's where most of your body weight is. Call it provider, or they have to call it advanced EMT. As far as special bariatric techniques and equipment, there are some different things out there to help you with weight distribution. And they make like the hover jack system. You ever heard of that before? So a hover jack is a flat surface, and it goes up in layers up to 4 feet high. So you use a hover mat and hover jack together. So you got a patient who's on the floor that weighs, let's say, 600 pounds. You got to get them up off the ground. You log roll them underneath this hover jack with a hover mat. You inflate it, go up in sections, 1 foot at a time, so it's up to 4 feet. This thing will slide up and down. It has like a carbon fiber bottom, which will allow you to drag it over like rocks. It won't rip it. Apparently, it won't rip. Up and down stairs. It has a harness system built into it. You get them up next to the stretcher, and you inflate the hover mat, and then you slide over it. It's very minimal strain being utilized. So when you if any of you do ride time at Action Ambulance, they have one on their rescue truck, on their rehab unit. They have one on that. And you can always ask your preceptor, if you're working in Tamworth, where it's located, to kind of take a look at it. I'm sure they'll pull it out for you. But as far as bariatric units, I don't see many of those anymore with the ramps and the winch system. Because of the power load systems, they can take so much more weight now with the new stretchers that I really haven't seen many of those around. Like Northeast Ambulance used to have one. I doubt they even have it anymore. It's going back like 15 years ago. And AMR had one they do.
Yeah, I seen it about a week or so ago.
Okay. Yeah, not many systems have them anymore. They've got rid of those true bariatric units with the winches and ramps. If you're in the Ossipee Valley area, Conway Fire has that system for one of their trucks. It's the Carroll County, they call it the Carroll County cache. Every county got a cache of bariatric equipment that can be utilized. So last I knew, Conway Fire had it, unless they gave it up, but they had it as of last year. So again, know your resources and what people have around you. And there may be times where your patient has to wait because they're too big and you have to wait to get them out. And the way life works, your heavy patients are always on the second floor. So carrying a patient up and down the stairs, ensure that you have the two strongest advanced EMTs are positioned at the head and the foot end. Do not attempt to lift and carry the patient in a significant distance if you believe that you are approaching maximum capacity. So all they're really saying here is know your limitations of what you can and can't lift. And when you get on scene, make a determination early. We're going to need manpower. Do not wait. And if it's a frequent flyer that you go to all the time, then automatically start manpower right off the bat if you already know. And sometimes dispatch will actually find out, patient's weight as well. And they'll say, patient, is a bariatric patient. Do you want more manpower? Absolutely. Please send them. If we don't need them when we get there, we'll call them off. But at least you have them coming. Right. So planning to move the patient in an orderly, planned, directed, unhurried manner. Anytime you have a sick patient you need to move inside of a house that you're going to have to get out, whether it be 120 pounds to 450 pounds, it doesn't matter. If you have another provider there that can scout it out to find out the best way out, find it. Just because you walked in the front door does not mean it's the best way to get a patient out of a home, right? It could be the back porch, which goes onto a grass area where there's no lifting involved down 5 or 6 steps, right? So scout it out how you're going to get a patient out of the home before you start moving them. And the best time to do that is when you have your partner. If you're not the primary tech, have your partner look really quick. All right. Select methods that involve the least lifting and carrying. I like this one right here. If I don't have to lift the patient, I'm not going to lift the patient. Right. So the least involved maneuvers. Right. The diamond carry is used to lift a patient on a backboard or stretcher. So you have 4 providers, 1 at each head and foot. So if this is the backboard here, like this, we'll have 1 provider here, 1 here, 1 here, and 1 there. That'll allow us to carry the patient out. Okay. But as we approach doorways, as you can see in this photo here, we're diamond carrying. This is the diamond carry here. Sometimes you may have to stop, and the stronger of the 2 should rotate to this location, get them through, and then go back to your diamond carry once you get through the door. Right. If you don't have 4 people, then you can make your lifts and move. But if you need manpower, call for it. The one-handed carrying technique, so 4 providers use 1 hand each to support the backboard. It's not a bad thing, but if you have bad grips, then you should really be walking with 2 hands on the board, but you can use 1. I would never, ever use 1 hand on the back side of a board or front side of the board as far as foot and head. Always have 2 hands. Right. So yeah, I guess this is definitely a skill. Doesn't mean it's right. So if you have your person on the board like this here, I would double hand, and you could single hand here, put S's for these on those sides if you want to, but never single hand front and back. That would just lead to disaster. For emergency moves, these are for potential for danger before assessment and care is provided. Before you ever move a patient, you should always do an assessment first, vital signs, everything else. However, there are certain times where we have to get a patient away before we do an assessment, such as fire, explosives, hazardous materials. The inability to protect a patient from other hazards, and the ability to gain access to others in a vehicle who need life-saving care. Right? So if you can't access the vehicle on the passenger side due to significant damage and the driver is okay with a broken ankle, pull them out and get to the patient that's unconscious next to them. Right? There's times where you can do what they call rapid extrication. Also used when can be used when you cannot properly assess the patient or provide immediate potential critical emergency care because the patient's location or position. We need to drag them out of the vehicle. If you are alone, you can use the drag and pull method patient along the long axis of the body, keeping the spine in line as well. Those are more like your commode codes, things like that, or cardiac arrest next to the bed. You need to move the patient out to a living room and move things around. Right. I'm not opposed to flipping a bed on its side in somebody's room to make more room to work. Right. You got to do what you can to make sure people are, I don't want to say the word comfortable, but have places to move. So emergency moves may actually happen in order to get enough access to the patients to be able to provide proper care. Right. So to move a patient like this, you can use the blanket drag, which is here, blanket drag, or you can do a shirt drag using both sides here. Be careful and rip the clothes right off of them. Other ones you can utilize are the arm drags, or you can do like the fireman drag as well, where you use your hands, and you can drag this way. You can use your hands. You can drag them along the floor, right? I've used this one here more for cardiac arrests. I got a patient in cardiac arrest. I grab them by the hands and I drag them out. Just please be careful of their head and their neck and don't bounce it off furniture. I understand they're in cardiac arrest, but take note. We don't want to cause another head bleed or anything else either, or it just looks bad for the patient, for the family when you see that kind of stuff. Other methods, I've seen this one here used a lot in the fire service and fire programs. Rarely do I ever see anybody carry anybody like this out. Other methods you can utilize, obviously, to assist somebody that's, say semi-responsive or whatnot. You can use this carry here or lift and carry. I've seen this one here used more in the fire service than anything else. And again, I don't see this one here used much in EMS, but it's still available to get a patient out and move. So again, just be careful on your different drags. Urgent moves are necessary when a patient requires immediate life-saving care in an unsafe environment, like extreme weather conditions. So a patient with altered level of consciousness, inadequate ventilations, or shock when care cannot be rendered where a patient is currently located. All right. So kind of keep that in mind. Rapid extrication techniques should be used when a patient is sitting in a vehicle or must be urgently moved. So using extrication type vests, short boards, devices, or a seated patient with a suspected spinal injury could take 6 to 8 minutes or more. Or if you use like a Kendrick extrication device, a KED, which a lot of people don't even have those in ambulances anymore, but they are still utilized. If you look in your books, table 6.2 describes the situations in which you should use rapid extrication techniques. So take a look at those. And then also there's greater risk for spinal movement as well. Non-urgent moves are when both the scene and the patient are stable. So carefully plan how you get the patient out. I think we already discussed this a little bit earlier. Have someone scout it out. How are we going to get this patient from point A to point B without hurting them? Adapt procedures to meet the needs of a case-by-case basis, right? Don't put yourself in harm's way, and don't put yourself in harm's way or the patient as well. All right, direct ground lifts. Patient used for patients with no suspected spinal injury or who are found lying supine on the ground. Right, those are direct ground lifts. If you find a patient semi-prone or lying on one side, roll the patient onto the back, ideally performed with 3 providers, but it can be done with 2, right? I've seen this happen a lot going from a stair chair to a stretcher if they can't walk. Is someone gets underneath the legs, someone gets underneath the shoulders and the armpits, and they lift and bring them over on a 3 count. Right. So different things you can utilize. Extremity lifts the same way. If you have to carry extremities, bringing a patient over. For those with no suspected spinal injury or found in a supine or in a seated position. Excuse me. So transfer moves, direct carry methods used to transfer a supine patient from a bed to the stretcher. To perform this method, you can look in your books at 6-9. The draw sheet method, which we do a lot of, used for patient moving from bed to a stretcher. Perform this method, just look at skill drill 6-10. And then other carries, but utilizing a backboard, scoop stretchers, things like that. And all of you should be very familiar with how those already work. All right, so geriatrics, the things we gotta look for obviously are curvature of the spine, like scoliosis, things like that. This can be very painful. This can be very painful on these long boards and everything else. Okay. Or your patient might have brittle bones like osteoporosis, rigidity, spinal curvatures like kyphosis or scoliosis. Many patients also cannot lie supine on a backboard or scoop stretcher without causing further injury. So if you're going to deviate from something, be utilizing something, then just document why you did it. All right. So care and creativity must be also utilized for mobilizing patients with these types of conditions. So if they have to be on a board, do we put extra padding down, right? Different blankets, things like that. What are some different methods we can utilize to make sure that the patient will still remain stable, but in turn also make sure they don't have a lot of pain. Right? We talked about doing no harm. Let's do our best to try not to do any harm, right? And also you can contact local protocols or your medical director about alternative ways of immobilizing the patient, right? And make sure you're also filling voids. One of the things that works phenomenal, and we used to do this a lot back in the early 2000s, when we used to backboard patients all the time. They would have lower back pain. We keep them on a board, right? I used to take a blood pressure cuff and stick it underneath the back and inflate it, take the pressure off. You'd be surprised at how much pain relief there actually was with that. Just by filling a void with something. And I used to use a BP cuff all the time for that. Slide it underneath, nice and flat, inflate it until the pressure goes away. Amazing what that can do. Right. Other thing with geriatrics or skin changes, like delicate skin, is prone to tear, bruises, or even during the simplest moves. Protect the elbows when carrying and moving through hallways, okay? Because their elbows can hit things and they can just have skin tears, right? The other one is fear. So our best bet is to allay the patient's fear with a sympathetic and compassionate approach. Slow down, explain, anticipate, right? Plan for the unexpected that are there, anticipate what potentially could happen, and try your best to avoid it. Right. So bariatrics. From 2017 to 2018, the prevalence of obesity in adults in the United States was 42.4%, according to the U.S. Center for Disease Control and Prevention. Approximately 18.5% of all children ages 2 to 19 years of age in the United States are classified as obese. 18.5%. Bariatrics is the branch of medicine concerned with management of obesity and allied diseases. There's a direct correlation between the degree of obesity and the frequency and severity of health problems. This problem takes a toll on healthcare workers because of back injuries. Equipment is being produced with even higher capacities, but by increasing the capacity of something it can do, may also add more weight to that device you're utilizing, right? Do not address the dangers. This does not address the dangers posed to the users of the equipment, and mechanical ambulance lifts are used in Europe, but not as much in the United States. Right? We're seeing more now of the power load systems, but they're not cheap. Right? It's not a mandate by the state because it'll be unfunded because the state's not going to be able to afford anything like that at all per service. But services really should be looking at getting them because one back injury could be $200,000+ lost per year. Factor in the injury itself, the workers' comp being paid out, which is like 60% of your last couple paychecks. So if you commonly work 75 hours a week, that's what they're going to base it off of, your 60% of your pay. On top of that, they have to pay for all your therapy, medications, and they have to fill your shifts with overtime. So the cost to a service is phenomenal. So as a service chief, why we don't have more power load systems out there is beyond me. Because it's cheaper to pay for that money right off the bat than it is to pay a long term with a workers' comp claim or potential lawsuit. All right. Enough of that noise. All right. So patient moving equipment. So wheeled ambulance stretchers can be rolled along the ground and weighs between 40 and 145 pounds. Said the more equipment on it, the more it weighs. Generally not taken up or down stairs. And I see this happen all the time. Up and down stairs with stretchers. That's why they invented stair chairs. All right. Utilize them. Or the patient can be carried rather than rolled for any significant distance. Available in many different models. And I've seen some with SCBA models running them. I've seen them with batteries. There's all different ones that were out there. But the two major ones that have happened now are either Stryker or Perno. Those are the two biggest ones that I've seen out in the market now. Stretchers have a specific head and foot end. And stretchers have a strong horizontal rectangular tubular metal frame. Right? Stretchers should be pulled and pushed and lifted only by the main frame or its handles. Right? Most models have a second tubular frame made up of 3 sections that is attached within or above the main frame itself. As you can see on here, this is one of the newer Strykers. So your hydraulic systems are all here, right? Anything with red is movable part. The battery located here, red part there. These side rails now can fold down a little ways and make it wider for a patient, which is nice, right? This one here bends at the knees to put a patient with bent knee. Abdominal pain works great for abdominal pain patients, right? But now we're adding all this extra weight. We're adding oxygen bottles and everything else to it. Now the normal weight of the stretcher. Now we're adding more stuff onto that as well, right? So just be aware and how to utilize what you guys have for your system. This right here is a bariatric stretcher. It's specialized. The problem with these here is they're not power, but they can hold up to 1,000 pounds. I think it's 1,000 or 1,200 pounds flat on the ground, right? So these handles here are utilized to wheel it on either all the way down or up one notch, right? And then there should be a hook located here that you can connect your winch cable to as it goes up the ramps like this into the back of the ambulance. And there's a winch usually underneath the airway seat. Right. Special training is definitely required to utilize those because there's a lot of pinch points and you just got to be careful. Right. These are your powered stretchers as well. This one here is hydraulic. However, it does not have all the bells and whistles as you saw in the first one. So again, it's not my place to teach you guys about strikers and furnace, which one's better, which one's worse. It is for you to learn what your service has. Right. As you're walking the patient or wheeling the patient, as we saw here into the ambulance, right, I always go feet first. When you go into an elevator, go head first in the elevator so the patient is wheeled out feet first, right? If you're going up and down stairs, you got to make sure you retract the carriage so that way they're not hitting the wheels. Oh, lost connection again as I touched it. Right. So as you the wheels here, you want to bring that in up position. Around corners, you may have to sit the patient upward as this back rack can go in this direction here to make it a little bit smaller, but do not lift unless that is all the way back out again. All right. There's different things you can utilize with these. Some stretchers include IV poles. I've always been big on having 2 IV poles on a stretcher, especially for interfacility transport. If you're carrying multiple pumps, but not a lot of services do that. But IV poles are there. Please make sure that you actually tighten the IV poles up because they do slide down. So just be careful of those. Carried. There's a carrier in the back that actually holds your cardiac monitor, AED, or portable oxygen units. And there are also some extra wheels below the head end as well that help support it when it's on the ground. Folding stretchers. Right, I haven't used one of these. I can't tell you how long. But some ambulances still carry these. Right, they weigh a lot less and they're easier to get the patient in and out of residences and things like that. No different than using a scoop or a backboard. The other one's the Reeve sleeve. Reeve sleeves are really good too. As a lot of services have those on their ambulances that I've seen as well. Flexible stretchers. Right, I've seen a lot of these used out west, where they have like you're seeing like a vacuum splint, kind of like the same thing like full body splints. I've seen those before. You also have like the what are they called now? Like the hover mat, but it's I'm drawing a blank. I'm having a moment. If anybody remembers what it's called, but it's mega movers. That's what I was trying to think of the name of it. Mega movers are out there as well. All right, you can use those. Backboards. I don't think I need to go much in depth in this here. These are backboards. We've all used them before. This is a KED. Has anybody used one of those before? Anybody old enough to remember how to use these in the ambulance? I see one hand going up. Might be others. All I can see is Mike's picture right now. So KEDs were utilized a lot. It was a big thing in Maine. New Hampshire, when I first started New Hampshire, they were there, but they sat on an ambulance. Me personally, I like using these for pelvic fractures. Reverse the KED, put it on the pelvis. It's a great pelvic stabilization device. But these were initially designed to remove patients out of cars that had spinal injuries that were low acuity and more low acuity patients that didn't require rapid extrication. And honestly, for the longest time, for main providers, I don't know if it's been a main provider since like the early 2000s, but like 2001, 2002, this was actually a med control order to use this in Maine for a while. Yeah. If you go back to the old protocols, everybody still did it anyways without calling, but if you looked at it, it had a little phone next to it. It was actually a med control order to use a CAD. But history is history. It's always good to see how we've evolved since then. The vacuum mattress, all right, this is the thing I was telling you about before. The vacuum mattress is here. It fits snugly to curvatures and contours of the body. I haven't seen many of these in the East Coast. A lot of the research that I've done on these here, they use them out west. Why it hasn't made its way over here, I don't know. Not sure why. But it reduces hypothermia, provides a high degree of immobilization and comfort. Literally, it's a vacuum splint, but a full body splint.
Those suckers are great for hip fractures.
Absolutely. They are. Have you had a chance to use those?
Yeah, we have one on each of our trucks.
Nice. And not many services have those, the full body vacuum splints like that.
Stephen
So,
King Grant got those for us.
Perfect. That's a great grant to get too. I'm glad you guys have them because it's one of those things that needs to make its way over to the East Coast. These are called basket stretchers. Another name would be a Stokes basket you can utilize. Not the greatest to put inside the ambulance. It takes up a lot of space, especially if you use the ones for water rescue and you have the water ring around it as well to make it for a flotation device. And those won't easily come off. Usually they're either Velcro or they're snapped in somehow. So what I recommend if you're going to have a patient that you're putting into a basket is have a backboard underneath it so you can easily get the patient out. Backboard, scoop, doesn't really matter. Just have something underneath it that you can get the patient out of that board, out of that Stokes basket. Makes life a lot easier. There's different types that are out there. There are metal ones. There's like a mesh style. They have the plastic ones like this. They have plastic with metal rings around it. Jenkins makes one similar to that. And just different ones you can utilize. Normally, you don't find these on ambulances. They're usually on heavy rescues or an engine somewhere. Ladder trucks. This is a scoop. I love the scoop stretcher. I loved it back in 99, 2000 when they were big. Then they kind of went away for a while and like, no, we don't want to use it as a scoop stretcher. Now they're back. These are a little bit cheaper to purchase. The plastic ones are close to $1,000 a scoop. But these are great for hip fractures because you don't have to roll a patient. The curvature on these here work phenomenal for the Lucas device, like I mentioned before, for cardiac arrest. So there's a lot of different things you can utilize the scoop for. And it's easier so you don't have to roll the patient when you take them off. Let me just go back one here. Remember that these are pinch points. I've seen people rip skin before, break fingers because they get caught in these pinch points. So just be careful when utilizing it. These are stair chairs. These are the ones with track system. This is the Furno version. I personally like the Striker one better. I think it's more rugged, but Furno also has this as well. So the handle goes up and down here, so you can wheel it around. These extend out this direction here. The tracks come backwards like that, and you can go up and down the stairs with them. And mostly for down. They do make Striker. Striker made a motor for these. You go upstairs with them too. I know they still make them. They had this thing for a while where they're advertising a motor that you could attach to these things so you can go upstairs. I don't know if I'd spend the money on it. You can carry perfectly fine. Right. So moving a patient on the stairs with a backboard. If you do not, let's see if I can draw this out for you too on a bigger screen. Do not use a stair chair if the patient is unresponsive. However, Striker has a headband that goes on the, let me go back one here. On this part right here, they make a headband, a black Velcro headband that goes across like this. You literally can strap your patient's forehead in. So they have those options too. But again, if they're on a backboard, you got to make sure you strap them in right. So if this is your board here, okay, you want to make sure you have a strap across the feet, strap across the thighs. I'm going a little too high here. One across the a little bit higher. There we go. One across the torso, and then cross them like this, and then use a 9-foot strap. Come up here, go around, almost like handcuff knot. If you those remember the handcuff knots from fire school, if anybody's a firefighter, almost like handcuff knot it and come back up around, and then tie it up here. So when you lift the patient up from, let's say this is a stretcher on my pen, to a more of a vertical position like this, the patient doesn't slide down the board. Right? You want to make so it takes a little bit more to it, but you want to make sure you really secure that board and the patient to that board if you're going to move them, because you might not be able to get around a corner and you might have to go vertical with a stretcher or with a backboard. And if they're not secured down, they're going to slide off of it. Right? So that bottom piece of that handcuff knot down here makes it the patient doesn't slide down because the weight is taken on the feet. And you also have them cross strapped and then torso, leg, lower leg strapped in. Right? This is a neonatal isolette. These things are very heavy. They're used for critical care transport, and they're used to safely transport a neonatal patient. Remember, neonate, something you hint to take a note on. Neonate is newborn to 30 days. After 30 days old, they become an infant. Okay, so anything with neonatal care is discussed between that age range. This is your neonates. Mostly you'll see these in preemies. They keep the neonatal patient warm. They are moistened with clean air inside and protect from noises, drafts, infection, and access handling. So these ports that you see here, or for our hands as providers, paramedics, whatever it may be, or EMTs, to start working on the patient inside. Right. So you don't have much room to play with. These are what they call isolettes. Right. Our ambulances that we have in 911 setting are not designed to transport these. I have seen them attached to like Stryker stretchers before, take the mat off and they've like secured them on that way. But there are different methods of transporting these, but these things are not heavy. They also come with built-in oxygen tanks and medical air as well. So there's a lot to an isolette behind it and a lot of advanced training you have to go through to be able to use them. All right. As far as decon, I don't know if I need to go over this in depth with you guys. Decon everything, clean stuff down, wipe stuff down, and prevent any kind of further infection. I think you guys have all been EMTs through COVID, I believe, all of you. Right? Still going through it. We have to decon stuff and clean things. The other day, I had 2 patients in a row, one with TB. The first one had diagnosed TB in a 911 call, and the second call I went on was a diagnosed RSV. So both calls had to get full decon in the back. What are my luck of getting a TB patient and RSV patient back to back? But something to think about. Just make sure you're deconning. You never know what you're going to come into. As far as patient positioning, position the patient in position of comfort, right? So patients in shock really should be in a supine position to distribute the load to reduce any kind of extra workload. We'll talk about that in shock therapy and treatment. Patients with spinal injury also should be fully immobilized. This is the national standard. The national standard still uses backboards. All right. We do not. Maine, New Hampshire, we've gotten away from backboards as a stabilization device for a splint. We're now using them as extrication only. Patients in their 3rd trimester of pregnancy should be positioned on the left side. Why is that? What syndrome is that called that we're preventing?
It takes the blood flow. It prevents it from backing up on the heart.
Right. So called supine hypotensive syndrome, right? Because the weight of the fetus is up against the vena cava, causing the blood pressure to drop. Right. That's why we place them on the left side. It takes the weight off that vena cava, allowing for blood flow to continue, preventing supine hypotensive syndrome. Right. We get into obstetrics. We'll cover that pretty in depth. You guys go over all the different obstetrical emergencies we're going to come in contact with in high risk OB. So place on a responsive patient with no suspected spinal, hip, or pelvic injury in a recovery position. Right. This prevents them. So if they do vomit, it protects their airway. Right. We're going to transport a patient who is nauseated or vomiting in a position of comfort, but manage the patient and maintain a patent airway. You as an advanced EMT have the ability to give somebody IV Zofran. If they are nauseous, we're going to administer it as long as the patient can take it. All right. I'm not saying do anything prophylactically, but we want to make sure we're treating these patients to prevent anything from happening. All right. Maintain the dignity of the obese patient as well. As far as medical restraints, they're not commonly used. We're going to first evaluate the patient for correctable causes of combativeness. So AEIOU tips, the altered mental status acronym that we utilize. Follow local protocols and obtain medical control authorization if necessary. New Hampshire, it's standing order to restrain somebody. It's not a medical control order. All right. Restraints require a minimum of 5 providers because you have to be able to restrain somebody the appropriate way. So one arm is up like this behind their head, while the other arm comes down to the front, and we secure their feet. Right. We have to maintain the best ability not to hurt a patient while doing so. Right. But other things that could include the evaluation would be hypoxia, hypoglycemia, head injuries, things like that could cause a patient to be altered. The last thing we want to do is restrain them. We want to fix the problem, right? Giving them sugar, oxygen, right? Or calling for a paramedic for sedation with medications instead, especially if they have a head injury. Versed works phenomenal for that. So contacting ALS with paramedic would be very beneficial for that. Ask yourself 3 questions before moving a patient. Number 1, first thing you want to ask. All right. Am I physically strong enough to lift or move this patient? Number 2, do your best to maintain a level of physical fitness. And for that, number 2, is there adequate room to get the proper stance to lift the patient? If not, then we need to drag them to a place where we can. And number 3, do I need additional providers or lifting assistants? Remember, an injured provider cannot help anybody. You get hurt on scene and you have to be transported. Now we have 2 ambulances. We need to require 2 more ambulances to respond, right? Because now you just became a patient if you can no longer lift and you're dropped to the ground in pain. All right. Let me turn off the recording really quick.